Have no time to do anything else. Just get your terminology and words down because they will just be used kind of offhand, and you'll kind of need to know what those things are. So that, if, as a minimum, I think that'll be helpful. What we're going to finish up today is the rest of the mood disorders. So we'll finish up depression, and we're also going to talk about bipolar so that we have the range of mood disorders. And then second half of the morning, Dr. Latassi is going to come down and talk about the drug therapy, and we'll give you a basic outline, and then we'll let her go into all the details about those. So by the time we hit noon, you'll be pretty much done with your mood disorder content, and then you can start working with that. This afternoon we have two people. We have feeding and eating disorders, and we also have the suicide piece and the QPR training, which I haven't ever been through, so I'm going to kind of be curious how she actually does that piece of it. So by the end of the day, you'll have gotten most of the things that are kind of thematically tied together, because eating disorders and feeding disorders are also fairly commonly seen with depression in children too. Okay, so let me get over here, and I'm sorry, I tried to get this advanced to work, so I'm not so tied here, but I'm kind of tied here because I'm going to keep using this to kind of advance ahead. But let's look at differential diagnosis. We ended up yesterday at major depressive disorder, and there are many things that can present with symptoms that look like major depressive disorder, and y'all know that from in the neurology module there are many organic disorders that may present that way. So the differential diagnosis really is almost everything that can be organic in basis that could cause depressive symptoms. So, and you will see this be fairly common for almost all these psychiatric disorders. You evaluate for everything, eliminate organic causes, and then you're left with just behavioral, mental disorders. Did y'all like House? Did y'all watch that? Pretty good. Okay. Several things listed here. All these infectious processes, malignancies, so viral illnesses, malignancies, endocrine disorders, particularly thyroid, adrenal function problems. Remember I said yesterday that one of the theories for depression is the axis, the HPA axis, so you can see psychiatric manifestations when those hormones are not in balance. Hematologic disorders, anemia could be one, also cerebral vascular disorders and cardiovascular, so post-stroke, post-MI. Others, collagen vascular diseases, that's a wide range of things, including lupus and rheumatoid arthritis. CNS disorders like Parkinson's and Huntington's. Drugs and toxins are big. I've just given a few. Corticosteroids. Steroids cause a wide range of psychiatric manifestations, from giddiness, euphoria, got energy for the world, to very depressed. So anytime you're using big dose steroids to treat anything, you really have to kind of pay attention to the way they behave, because you can see some quite dramatic behavioral changes. Personally, when I've used like a Medrol dose pack and just get a big blast, I feel giddy. I have a hard time sleeping. I mean, I just feel like I've got energy to burn. So I'm not really going to get the depressed side of things, but it really does kind of rev me up. So you'll see that, and it's not uncommon. In fact, it's fairly common. People will feel different on steroids, and one of the reasons why I have a hard time getting people off the steroids for other disorders is not just the fact that you're trying to wean things down so they don't have a big dose of steroids and get axis suppression. They don't like the way they feel when you pull them down because it's so elevated, for some.
So when you discontinue the steroids, does it take away the symptoms such as
They should. And and steroids you're always going to taper if they've been used in big doses for a long time, but you gradually take them down. And that's one reason you do that. You just gradually bring the person's changed mood back into normal without being abrupt. You just throw them off. Then not only is the disease process you're treating likely to get reactivated, but you also may have behavioral changes with that sudden drop too. Okay? So all these things you're seeing, it's not like they turn it on and all of a sudden you're just messed up forever, but during that phase where steroids are in the system, you could see that. Also toxins, many things, antihypertensive drugs can cause it, sleep disorders. In most medical facilities, if you have a psychiatric hospital, they tend to have fairly prescribed admittance orders for patients, and it's usually fairly wide, and we look at the entry orders here shortly for major depressive disorders. You'll see that they're doing those. These are screening for infection, metabolic problems, hormonal problems, toxins. They almost always do drug screen, so that's just kind of almost routine. They're trying to eliminate all the other possibilities so that you're left with a psychiatric disorder. Okay. Here's some of the medications. I mean, it's just a handful. I'm just going to point out a few that are more likely. Beta blockers have a fairly good instance of that when you start them. Clonidine very notably changes behavior. And I'd say it's especially in older people, it could be 50% plus of people have some change in behavior. Another one, corticosteroids, we called out. Narcotics can have odd effects on behavior and mood also. So this is just a list. I don't expect you to remember every drug that causes depression, but I just want to pick out a few of those that are more notable. And you see them fairly commonly. Another disorder, we talked about major depressive disorder. Let's look at persistent depressive disorder. They're similar, but there are differences. Okay, it's similar to major depressive disorder, but the difference is in the length. Persistent depressive disorder has to be around for at least 2 years. And what was the length of time for major depressive disorder? Somebody said it. 2 weeks. Okay? Major depressive disorder, you had to have the symptoms in the right count, okay, for 2 weeks. To have persistent depressive disorder, also called dysthymia, 2 years. That's a long time. Many people with dysthymic have experienced almost lifelong depression. They're just dysthymic all the time, which would be an unfortunate diagnosis to have, honestly. Here's what DSM-5 says about the dysthymic disorder, the long-lasting version. Depressed mood for at least 2 years, so they have to have depressed mood, and then they have to have also 2 or more of the following while having a depressed mood. And so here's your list. It can be something that deals with appetite, overeating, undereating, something to deal with sleep, energy levels, and then low self-esteem, inability to concentrate, and feelings of hopelessness. So if they have a depressed mood and at least 2 of those other types of symptoms for at least 2 years, then they can be diagnosed with dysthymia, which is a distinctly different disorder than major depressive disorder. Okay, here's some more details to kind of clarify. These people are never without those symptoms for more than 2 months of time. So over this 2-year period, there would be only small episodes where they might not actually complain about that, but they would generally have these symptoms running for that full length of time. Now, it is possible that you could have a major depressive disorder that lasted 2 years, but there are more symptoms required. I'm going to bring you up a comparative slide here in just a second. Major depressive disorder is a shorter time period, but it has more requirements. There are more symptoms that are present. Dysthymia is a longer period of time, but there are lesser symptoms that have to be present, and they tend to present in a lesser intensity. Okay? To be diagnosed with dysthymia, you can never have had a manic or hypomanic episode. Anytime you have manic or hypomanic episode, whenever, they immediately become a bipolar disorder. So as long as they're just dysthymic, depressed, whatever, you're looking at one of those diagnoses. But if you ever can pick up mania or hypomania, they immediately become bipolar. I don't care if they're depressed 99% of the time. If they have one episode, they are a bipolar person by definition and will remain that way. Okay? The symptoms cannot be explained. These are all the DSM-5 lingo for almost every disorder. They can't be explained by another psychic disorder. They cannot be a substance abuse-related thing. They cannot be from other medical illness. So that's why you have big rule-outs to begin with. The symptoms there are some symptoms of major depressive disorder that are not present in persistent depressive disorder, so I just listed those out. You see, they don't have anhedonia. They can have a depressed mood, but they can find a way to be interested in things. It's not that they don't have interest in things, but their mood is just down. They don't usually have weight loss issues or weight gain issues. They don't usually have psychomotor agitation or retardation, and they don't have these recurrent thoughts of death, suicide, or making a plan. So they're just a down mood, but it's not to the extreme, to the place where you want to end your life, you feel out of control and want to end it. Okay, I'm going to skip premenstrual dysphoric. I've just made an editing decision. I'm going to leave it in here. You can see it, but I'm not going to expect you to know it for testing purposes. Your objectives will reflect that. And I was telling Andrew, I'll have all the objectives up tonight for all the things that we've covered through today. So hang on. I wish I were a little bit ahead of the game, but I've been dealing with other things I didn't want to deal with. But, and I apologize for that. It's not the way I like to do it. Okay. One last comment. Anxiety. You will very often see anxiety disorders joined together with major depressive episodes. And there's actually a diagnosis unique. It's depression with anxiety, and we'll get that when we get to the anxiety disorders the first of next week. We'll talk about how that kind of plays into the diagnostic criteria. I got it done.
Yeah,
I did.
okay. Dan said come down and check on you just in case. So we were just making sure you got everything you needed.
Yeah, I'm
We
ready.
knew you were down by yourself. Thank you.
No, I'm okay. Thanks. So you see anxiety with depression quite a bit. No, we'll be okay. But just to go back and review real quickly, major depressive disorder, all in the same 2-week period. You have to have the mood or anhedonia problems. Then you have to have off that list, you have to pick out some others to get up to 5. This one is 2 years, depressed mood, and then 2 other symptoms that are also present. Okay, so they're a difference of intensity and duration. So you can see how psychiatric diagnosis gets kind of messy over time. You have to have fantastic history to figure out what's going on with people. I think it is kind of difficult to know what your diagnosis is sometimes. So let's look at the assessment of patients with depression. Okay. In regards to appearance and affect, it's kind of what we talked about the other day. They can usually have a normal appearance, but they may also have decline in grooming or hygiene depending on how depressed they are. Some people are depressed. Dysthymic people look kind of okay, but they're just kind of down. Major depression people may move on to really not take care of themselves or grooming, so it depends on how far on the spectrum they are. Psychomotor retardation and flat affect can be present, and some have psychomotor agitation or restlessness. So you don't always see the same presentation. With most psychiatric disorders, you're looking for the constellation. And you see, diagnosis is not like other diseases. You know, with blood pressure, if you hit a certain blood pressure reading, it's classified this way. With psychiatric disorders, there are usually a list of symptoms that have to be present, things that are not present, durations, and so you have variations in the presentation of the disorder. And I think that makes it messy for some people who like very clean answers. These diseases won't always present the same way, and they won't have the same diagnostic criteria. One person can have major depressive disorder, another person can have major depressive disorder, but they may not have the same set of symptoms. This one oversleeps, this one doesn't sleep. This one is overweight and eating, this person doesn't eat anything. Both have the same diagnosis, but the presentation is different. So when you're playing the DSM-5 game, you have to be able to know what's required to call the diagnosis to actually put that ICD-10 code down for it. Mood and thought process. Mood is usually sad, heavy, numb, can be irritable, loss of interest or pleasure, as we talked about. Thinking is almost always negative. They feel hopeless, helpless, and worthless. The 2 H's and the W, hopeless and helpless. That is kind of the thing you'll hear. Delusions are sometimes, but not often present, so they can have some delusions, particularly with severe presentation. Speech is usually normal. They can articulate, put words together, no problems with syntax, but it's slow. They can be monotonic. They don't get excited. They don't go down. They're just down. No spontaneity and not a lot of content. The thought content, usually they talk about being overwhelmed, don't know what to do, don't know how to get out of bed in the morning, don't know what, everything seems too much, I can't move, I'm just going to stay home. They can't find that mental energy to go do things. They feel inadequate, again, hopeless, worthless, and helpless. History, when you're looking at the history of a psychiatric patient, particularly when you're looking at major depressive disorder, it is very helpful to get family history because there are commonalities in families. So if there's a family history of major depression, that could be helpful. Not definitive, but helpful. neurologic illnesses, exposure to agents, so you're getting the med history, and then also the history of chronic pain, medical illness, and psychosocial stress. You know, in chronic pain and chronic diseases, depression is very common. You can make that diagnosis. So anytime you're treating a patient with multiple chronic diseases and or pain, you have to have depression high on the list. And you will very often see those patients, when you're treating them, have a laundry list of medications, including antidepressant medication, because it clusters, they all cluster together. Here's some of your workup considerations. Some of these you might be able to eliminate based on the history and the physical, but it's a wide range of things. Again, it's everything in the body that could be organically producing a depressed symptom. So CBC for infection, TSH for thyroid, ANA and ESR for either infection or autoimmune disorders, B12 for anemias. You can get some significant depression when you have a B12 deficiency. RPR, HIV for sexually transmitted diseases, CMP, blood alcohol tox screen, I see it as a standard for admission in most places, blood gases, DST, if you're looking for Cushing's, if there's a physical appearance that might go with that. CT, MRI, EEG, all of those things would be based on their presentation and other neurologic disorders that you might think were suspicious enough to be ruled out. Everybody with major depression is not going to get a CT scan, but if you have other, focal neurologic signs or other symptoms that might be suggestive. So these are workup considerations. And as I said, wherever you practice, they usually will have the standard of what you're going to do to try to screen somebody, and then if your history makes you suspicious, you might go and do some other evaluations, or rule these in or out first, rule in or rule out things initially, and then go further. Here's some questions you can ask. This is a little mnemonic that's kind of helpful when you're looking at people with depression. SIG, ECAPS. Have y'all heard that before? Who taught y'all? Where'd y'all first hear SIG, ECAPS?
I think it was the OP9.
Okay, that's fine. What topic was it presented in? Was it premenstrual syndrome?
It was postpartum.
Postpartum depression. Okay. So, it's the same question. So, that makes sense. Sleep, interest, and guilt. Energy, then concentration, appetite, psychomotor function, suicide. That covers almost the laundry list of all the things that you're looking for. You got 1, 2, 3, 4, 5, 6, 7, 8 in there. Complaints in 4 or more usually indicate a major depressive episode. Okay. There are some other forms that you can use too, like you can use patient completed questionnaires. I know y'all have had PHQ-9. Who first time? Just help me know where you are, so I don't waste your time redoing stuff. But y'all had the PHQ-9, right? I talked to you about, I think when we talked about chronic disease, coping with chronic disease. Did y'all have it anyplace else? She may have talked about it, okay. And then also, Beck inventory, the Beck depression inventory, the Zoom depression scale, and then the mood disorder questionnaire, which is specifically useful in sorting out whether or not a person has had mania or hypomania. So when you're trying to figure out, are they depressed and depressed only, or are they depressed and also have other mood disorders that might be going on, that is a really good screening test to use. And we'll look at it again when we get over to the bipolar disorder. But I have put each of these scales in your folder on the D2L, and you can look at them. They can be administered, the Beck Depression Inventory, they can take it. These don't take more than about 5 or 10 minutes to go through to actually come up with a score that will then kind of lean in one direction or another. The only problem you have using these scales in some practices is functional illiteracy. People can't read. And it's very difficult sometimes to figure out what level of literacy the patient actually does have, which is altogether another topic that we're not going to get into right now. But if that is the case, if they tell you they can't read, then you could administer to them, read the options and let them answer for you so that you have a more objective scale to work with. I gave you one PHQ-9 interpretation. I am not going to ask you to remember the scores and numbers. I just think things like that are not that useful because in the real world you're going to have the inventory, you're going to have the scale, you're going to look at it, and you're going to administer it and read it yourself. But this is the type of thing you'll see. On the PHQ-9, anything over 20 is severe, but scores 15 to 19 moderate, lower scores mild, and then a 0 to 4 means you may not need depression treatment at all. So most of the inventories you take will rank things out from no problem at all to major episodes. And some of the scales actually, when you go in to take a look at them, actually even start indicating treatment. Most of your scales, when you're severe, are going to indicate pharmacotherapy and or psychotherapy at the same time. When you get into mild and moderate, you have to start thinking about, do I want to use drugs or do I want to use psychotherapy? And those end up being judgment calls based on your assessment of severity. There is no algorithm of you have to do this in this patient. And that may be the problem sometimes, is when do you want to initiate drug therapy or not. I think in some cases people are very quick to use drug therapy when maybe they can get by with psychotherapy or counseling before moving in that direction. But that's an issue that you have to kind of work through yourself. But this, I give you this as an example so you see how they score out. But I would say look at those different scales I have put in your package. Just see how they question. You can see where they're coming from. There'll be questions about appetite, energy level, sleeping, and they make the person kind of assess differences from the way they used to be. And then that gives them a number. And then you add the numbers up. Usually the bigger the number, the worse you are. The lower the number, the better off you are. Let's look at treatment options, and I'm just going to give you a broad overview, and I'm going to let Dr. Latassa go in detail. We kind of coordinated what we wanted to say between the two so you don't end up having to get double duties. But the pictures are actually the three of the major forms. You've got electroconvulsive therapy here, medications, and psychotherapy. Any of y'all familiar with, they still do electroshock therapy. ECT still happens. I had a very, very good friend. She had issues with major depression most of her life, and when she's functioning, fully functional, when she wasn't, she was very non-functional. I mean, it was so dramatic, and to just know her that well, you could just see it. You could even see it coming on. But she had such recurrent bouts of major depression that were not always responsive to drug therapy that she actually got electroconvulsive therapy one time here in the city over at, I think it was Demas that actually did it. And it was a huge, I remember when that happened. So we were so worried, she had done suicide attempts and all of this. And then when we learned that they were going to do this, like, well, it may be the only thing left to do because she was going to kill herself probably. And the thing is, it made a major difference. I mean, a huge change for her. And she's done fairly well since then. Treatment options, there are really 4 categories of things you'll see. FDA-approved antidepressants, psychotherapy, ECT or electroconvulsive therapy, and then over-the-counter or herbal remedies. There's some things out there too. Antidepressant options, there are 4 categories of drugs you'll see. SSRIs, you've already seen, selective serotonin reuptake inhibitors. Just to tie it back, remember we talked about the biologic amines, the monoamines. Serotonin may be the regulating neurotransmitter, and when its levels are low and inappropriate, you cannot regulate the norepinephrine levels, so you may have mania or depression. So those drugs have become very popular and are generally first line. Serotonin norepinephrine reuptake inhibitors, another group. Monoamine oxidase inhibitors were the first agents, and tricyclic antidepressants were the first ones, but they tend to have some quite unusual side effects and drug interaction potentials. But they still have a place in patients who don't respond. Psychotherapy. Interestingly, this therapy has been shown to be at least as effective as medication in treating mild to moderate depression. That's why I say when you end up with a mild or moderately depressed person, generally you see people going to drugs because it's just easier, seems to be easier. But maybe it's not if they're not going to take it, if there's going to be complications or side effects. Psychotherapy should almost always be used in combination with drug therapy anyway. Electroconvulsive therapy is used for patients with major depression who are unresponsive to antidepressant drug therapy and psychotherapy. So these are folks who probably had a history of recurrent episodes, not well maintained or controlled on drug therapy and with counseling. and you may do that. It is also used when the patients pose a severe threat to themselves or others. Some people can get so, depressed that they want to kill themselves and everybody else. I mean, and particularly ones who have delusions when they are in a very significantly depressed phase. OTC and herbal therapy, I'm not going to get into the weeds on these, but I am going to say this. There is some positive information about some of them, but well-conducted studies are just not out there. The major issue with these over-the-counter herbs and treatments is that they have quite a few adverse effects, and Dr. Tess is going to present those, but they also have some significant adverse drug effects, so they are not benign. So if you just go into a pharmacy and are looking around for these things, okay, but what are you taking? Does anybody know you're doing that? I would not advise a patient to go shopping for depression treatments over the counter, unattended by a healthcare provider who kind of knew their whole history and their background, because patients don't tend to pay attention to the details of over-the-counter medications. Some of the ones that have good information, St. John's wort probably is beneficial. In Europe, it's actually one of the medicines that's kind of listed as legitimate. In America, we don't have the same information, and Europe does approvals differently than we do. So it's available out there, but it also has some major problems with bleeding tendencies. So if you're on anticoagulants or have issues with bleeding, you may not need to be on that drug. SAMe, omega-3 fatty acids, saffron, 5-HTP, and DHEA are some other ones that are available for use. The ultimate goal is to return the patient to a fully functional status. That's almost a done, but you have to actually think about what is fully functional status for that person, and you also want them to have a good quality of life. There will be ongoing assessment for treatment outcome. You have to do that. I'll tell you what's inappropriate, and I see this in primary care all the time. It drives me insane. Somebody comes in, you decide that they have depression, whether that's been decided correctly or not based on criteria. They're placed on an antidepressant drug, return to clinic in 6 months. What is that? I mean, literally, what is that? You think they're depressed, and you're going to go 6 months before you see them again? You don't even assess whether they take the medicine, whether it's going to work or not. That to me really doesn't make sense. Does that make sense to y'all? I mean, if you're going to put someone on an antidepressant drug and you think they're depressed, you better doggone well follow to see whether they're not depressed. Okay? And if it's not that big of a deal to you, then maybe they just need to be referred for therapy. But I think starting a drug and saying, see ya, is just not helpful. Okay, I'll get off my soapbox, but really, you see it often, and I don't understand it, and it's really not appropriate. Okay. Here's some barriers to treatment. When you hear this, you'll know why it's important to see people and follow up. Adherence. 25 to 30% of primary care patients treated with antidepressants stop the medicine in 1 month. Okay? So if you thought they were serious enough to get a drug, why don't you see them in a month to see if they're even using it? And then 40 to 50% stop it within 3 months. So you can pretty much say that if you're returning to clinic in 6 months, over half your people are not taking medicine anymore. So what's the point? So it's significant. Finances, insurance are one issue, as with all medications, but the other issue is the way it makes a person feel. You really have to kind of work with the patient on doses and what works for them. Pharmacotherapy for psychiatric disorders it's a nuanced approach that requires thoughtful diagnosis first, thoughtful selection, but good follow-up with what is happening with you. Because a lot of things that people would complain about, agitation, sleepiness, whatever, can be modified by working with different agents. And you need to at least be sensitive enough that could happen, that you can help fine-tune that person's medication selection and medication dose. It's a great service to do that. Physician-provider communication is another barrier. You know, some people give a screen, well, you probably have depression, let's start you on this. Not a good rapport, no follow-up. Okay, reasons for treatment failures. Limited time in primary care practices to arrange for mental health referrals. You know, there's the time required to address it and refer it is usually more than what a person has. If you're down to 10 and 15-minute visits and somebody sits down that's depressed, Unless you have a support structure like a licensed clinical social worker or you have psychiatric services in the same facility, it's hard to actually take it on. And it becomes very much a burden in a practice that is driven by numbers, so that can be an issue. The other can be the patient's unwilling to see a mental health professional, don't want to go see somebody, so, okay, they don't want to go, but you think they need to go. How do you leverage that? That's where SBIRT comes in. SBIRT isn't to force the hand, it's to actually use motivational interviewing techniques to create insight. You know, how likely are you to do this? You know, tell me some things you want for yourself. You start asking the questions that help them make that choice, is what it gets into. Professional lack of availability to mental health professionals. Oklahoma is not overloaded with mental health professionals. It's a major problem. The northeast Oklahoma area in Tulsa is much more supplied than is the Oklahoma City area. And I don't know why, and we just don't have it. And Oklahoma has one of the highest rates of mental health disorders in the country. We have a lot. So you would think we'd have better referral pods, and we just don't have that. Another concern, physicians are worried about stigmatizing the patient. You get sent to a mental health counselor or whatever, don't want that on your record. Patient doesn't want on their record. It's part of that insight and acceptance of what's needed. You can't get there in a 2-minute conversation. It takes more engagement and more relationship with the patient to actually navigate those waters. Okay, so here's some reasons why. So just to kind of wrap up major depressive disorder, it's very prevalent, very common. Primary care providers are in a unique position because they see this wide swath of humanity that comes through. Use your screening questionnaires to help. A lot of primary care practices do have their patients complete these screening questionnaires, you know, the waiting area, so you have something to work with, but they can provide you good information more quickly. And then you can begin working with pharmacotherapy or counseling or in partnership with a mental health care worker to actually bring about what you want. You can get responses. I mean, treatment is not a fair. You can get over 50% positive responses. You're not going to get 100% like I told you yesterday, but you absolutely won't be 0% either. So I think you're leaning to identify all that can be identified and then leverage all of those that you can in towards a treatment that's useful. Okay? So does that give you some feel for major depressive disorder dysthymia? That's the one distinction I want you to know, is those criteria and how they look and kind of how the workup is. And in a nutshell, the workup is rule out every other neurologic and/or systemic disease that might have depression as an indicator, and then that leaves you with your criteria, and that's how the diagnosis comes about. Okay. Do y'all need a little break, or want to go right to bipolar? We can do bipolar. We'll go bipolar. Then what we'll do is we'll stop at 10 till an hour. Okay. Let me get out of this one. Okay, just to restate again, we've been looking at mood disorders. We've started out on the depressed end, and we're going to move into the bipolar disorders, which actually go from a very depressed mood to a very elevated mood. And individuals can operate on that continuum from deep, deep depression to extreme agitation and elation and irritability. So you have this spectrum of mood, this continuum of moods that people can be on, and where they are on that spectrum and how often they stay in different locations actually fixes their diagnosis. So if they're on the lower end, the depressed end, then they're either going to be a major depressive disorder or dysthymia, depending on length of time and severity of presentation. If they move up that continuum and get elated, more excitation, more manic symptoms, then they move into the bipolar classification. So let's talk about where you have to be and how often to end up with these other diagnoses. They are difficult diagnoses to sort out, I'll be honest with you. Okay, bipolar is common. It's almost kind of a joke. People, when somebody acts kind of moody or crazy, oh, they're just bipolar. I mean, it's a joke word. I mean, y'all know, kind of act agitated or wild. But it's a very real disorder. very persistent, very difficult to deal with, very hard to manage. And as the primary care provider, I will tell you, when you have a bipolar patient, they're going to work you over at times. They really can try you. They can try your nerves. So when I see that I have a bipolar patient who come and sit down and will talk to that person, I just kind of prepare myself for a wide variety of things. And I'm ready for it because I know what I might be able to expect in that relationship. Bipolar, the disorders are characterized by periods of deep depression. They can alternate with periods of excessively elevated mood or irritable mood known as mania. So in bipolar, depression and mania can exist in the same person, surprisingly. Between the highs and lows, people can actually seem to function pretty good. So when you know people who have bipolar disease, there are phases where they're just like everybody else. There seems to be no differences. Then there are other phases where they're very depressed and can't really function well at all. And then there are other phases where they are hyper-functioning and dizzying almost in how much they can do. But if you're a person who's trying to relate to them, it's hard to establish the baseline of how I'm going to be with you because the person you're talking to is not the same person all the time based on where they are in their disease process. Okay, in the mood disorder spectrum, here are DSM-5 classifications. We talked about major depression, major depressive disorder, MDD. We talked about dysthymia, which is a lesser intense mood disorder that lasts for long periods. Bipolar II disorder is milder disease. They have depression and then they move up to what's referred to as hypomania. They don't become manic. And then you have bipolar I, which goes all the way to manic. Okay, we'll distinguish mania and hypomania here in a minute. And then there's another disorder called cyclothymia. We're not going to worry about the cyclothymia in this class right now. But those are people who oscillate between highs and lows. And some people oscillate very often. Almost, there are some people who do it within hours. This is an odd presentation, but there's some within days, some within weeks. So you really don't know where that person is going to be, and they don't know where they're going to be. They actually get frustrated because they can feel themselves going all over the place in the way they present. So major depression, low end, as you work your way up the spectrum, then it's bipolar II, which is hypomania, and then bipolar I is full-blown mania. Okay, that's how we're going to look at it. So and here's a little diagram to kind of help you see it. So here's the range. Mania on this end, major depression down here. Hypomania is kind of moving towards manic symptoms, but not full-blown. Then others, we have our good days and our bad days, okay, the good times and bad times. Then there is a lower level subsyndromal depression. Might have a sleep disturbance, might have a depressed mood, but that's it. They don't have all those 5, factors that are required. And then major depression where you have a lot of things. So, and there's the cyclothymic people. Most of us, we kind of run good and bad, mostly. Hopefully we're on this midline. But then other people actually go up into here and come down into here. Bipolar I actually goes into the hypomania, and then they go into, bipolar I goes into mania, and then they come back down. Bipolar II goes into hypomania, and then they go into depression, and they come back up. So bipolar II operates between the red line down. Bipolar I goes up into the red zone. Okay. Pathophys. Why do people have bipolar disorder? This one might be even more difficult to explain than major depression because it's just theories that people are still gathering together. We don't know, there's no marker, you can't do a blood test that says here's what you're going to be. But this one's interesting. There are structural defects that have been found in the brain in people who have bipolar disorder. And those defects are cortical defects, limbic defects, basal ganglia, and cerebellar structures can be defective. How they got defective is the question. Have they gotten defective because of did they get defective first and the disease showed up, or do they have the disease and they then have defects beyond that? We don't know. I don't know if it's, how that shows up. They do have defects in mitochondrial energy production in the brain. So there's parts of the brain that don't generate energy in all the cells properly all the time. Why, we don't know. And then another abnormality is electron transport and G protein coupling, which is actually how you bring processes about. A neurotransmitter binds to a receptor. The receptor brings forth all kinds of actions inside the cell. And when those G proteins are messed up and the electron transport chain's broken, things don't work. And that would lead to an energy production problem too. So there's something wrong inside the brain in processing energy effectively. That's about as far as I can go with it. Now we do know there's genetic, that there is a heavy genetic component. So if you're from a bipolar family, you have a pretty good likelihood of being bipolar yourself at some point down the road. So those family histories of psychiatric disorders actually help you. If you had somebody you weren't sure what was going on, but they had a mother who was bipolar, then you start thinking, well, okay, you have to entertain that maybe a little bit more. There are loci that have been identified on the genes, and we do know that twins and family studies show pretty good that there's a genetic component. And here's the most hard evidence. First-degree relatives are approximately 7 times more likely to develop bipolar disease than the rest of the population. That's pretty high. So that's a pretty good indicator that something genetic is happening within the families. Epidemiology, it's not that huge, 1 to 1.6%, but that's 1 in 100 people. That's a good number of people when you get into it. Morbidity and mortality are fairly significant. You can see those numbers. I don't care that you remember numbers like that. I mean, they're interesting, but they're not testable. I mean, you just need to know that there's big loss when somebody has a major psychiatric disorder. There's no racial predisposition for bipolar. And you remember in other diseases there can be racial and sexual preferences. Now, in the subcategories of bipolar, there are some differences. Bipolar 1 occurs equally in the sexes, and that's mania, people who have mania. Bipolar 2 is more common in female. That's folks who have hypomania. Okay? Rapid cycling bipolar disease. That's a term you'll need to be familiar with. They'll talk about, are you a rapid cycler? Where rapid cycling means how many episodes do they have within a year. 1 episode every 3 years is not a rapid cycler. 4 episodes in a year, more than that, can happen, and that's more common in females. Those patients are hard to treat because they are obviously not regulated and stabilized in their disease process. So you're looking at their history over time. You can't call anybody a rapid cycler until you've known them for at least a year, and you have to count episodes and then see, where they're going. The age of onset ranges from childhood to 50 years, so you could be, on up there before you had your first episode. Mean onset's about 21 years old. When I think of bipolar, I usually think of a late teenager, early 20-year-old person who has their first episode, and then it just kind of goes from there. So it is very possible that you have had contemporaries from high school or early college years that actually had bipolar disorder, because that's when it generally tends to manifest. Most cases start around 15 to 19, but there's another little peak where it's about 20 to 24. I think the average age of onset is about 21 for when you put all the folks together. Okay, so let's look at bipolar 1 disorder. This is the DSM-5 definitions. Okay, to be a bipolar 1, you have to meet the criteria for at least 1 manic episode during a lifetime. You can have 1 manic episode in a lifetime and you will forever be called bipolar 1. That's just your diagnosis. And it has implications in the future, because if you've ever had a manic episode once, you could have them again. But it is possible to have it once and never again. But it's not likely. Usually it happens again. The manic episode may have been preceded by and may be followed by a hypomanic or major depressive episode. It's interesting. Most people who have mood disorders that end up with a manic phase have other things that are going on. They've had other episodes, other mood expressions over time. Major depressive episodes are very common in bipolar 1, but they are not required for a diagnosis, and that's an important thing to remember. Many bipolar 1 will have major depression at some point in their life, but you don't have to have it for a diagnosis. To be diagnosed as bipolar 1, you have to have mania 1 time, and that's it. So we have to figure out what does mania look like to where we call them bipolar 1. So bipolar 1 Mania, one time in your life. Even though hypomania and depression, all these other things may swirl around you, once you hit the bipolar 1 diagnosis, that will take you from here on out. Bipolar 1 disorder requires at least 1 week of abnormally and persistently elevated expansive or irritable mood. Okay, so elevated mood, but the world, I can do anything, don't mess with me, you know. And, because you're going to have to remember that, they can be fun, then they just pop you. Fun, can do anything, get out of my way, type personality. But they also have to have abnormally and persistently increased goal-directed activity or energy. They may not always finish what they're doing, but they got things going. Like the one I was telling you, writing the book, conducting the movie, cutting hair, the world-famous hairstylists. They'll do a lot of things, but they may not finish anything. But they'll be busy doing it. The mood disturbance is sufficiently severe to cause marked impairment, socially, occupationally, or may necessitate hospitalization to prevent harm to self or others, or there are psychotic features. So mania is that one time, you have to have it, it has to last for at least a week, you have to have expansive, irritable mood, and or irritable mood, and goal-directed activity, frenetic pace, but it is sufficient to cause dysfunction. That is a huge distinction. Hypomania won't be dysfunction. They walk around amongst us. But mania has to be so severe that it disrupts functioning, and it can be so severe they go in the hospital. Manics in a manic phase can actually commit murder. They're wild enough and crazy enough that if you get in their way, and there's other irritations about, they could kill people. So there's this danger not only that they would hurt themselves, but they would hurt other people while they were in that phase. And often you find them in the criminal justice system because they've done things when they were in a manic phase. Okay, here's the deal. Let's go back and look at it again. You have to have one episode in life to be bipolar 1. You have to have at least 1 week of an elevated, expansive, and or irritable mood and persistently increased goal-directed activity or energy, and 3 or more of the following symptoms are present. If the mood is irritable only, you have to have 4. But if it's expansive and and irritable, then you only have to have 3 more. So the ones you can choose from, there's a lot of different things in here. Inflated self-esteem or grandiosity. Okay, they are so important, big, better than. Okay, it's just everywhere about their personality. Decreased need for sleep, 3 hours, 1 hour. I'm going to show you a video clip of the woman. She doesn't sleep. 0. More talkative than usual or pressure to keep talking. So that's that pressured speech thing you're talking about. Flight of ideas of subjective experience that thoughts are racing. It's flight of ideas or, it's a typo, it's flight of ideas or a subjective experience that their thoughts are racing. They will tell you, I can't stop my mind, it's just running and rolling and going and I can't stop it. They'll tell you that. Distractibility, easily distracted. You throw something else out there, they're off on it. Okay. Increase in goal-directed activity socially at work or school or sexually, or psychomotor agitation. They can be very promiscuous sexually and actually hitting on people and completing sex acts with different people. So they're very, they can be very engaging. You might go to a bar and be hit on by somebody who's actually in a hypomanic phase, and that's part of the way they are behaving. And they're fun too. They're just, if they're in a fun mood, they're just fun. So people are kind of attracted to it. Excessive involvement in activities have a high potential for painful consequences. This is how they get in trouble with the law. Shopping sprees, steal a credit card, overspend a credit card, sexual indiscretions, or foolish business investments. Let's say you're manic and you're 22 and you have sex with a 15-year-old girl. Okay, now you're in jail. Okay, why did you do that? I knew it was wrong, but why do they do that? So this could be explained with that. But foolish business investments, come with me, we're going to take we'll take all my family savings. I know we're going to do it because they're smart, bright, got all the energy, they know everything, everything is about them. They take the family's fortune and go put it in, a lake in Arizona, and then they end up losing all their money. Okay, The episode cannot be attributable to physiologic effects or a substance or another medical condition. They can't be high on meth. They can't be on crack cocaine with all this craziness. That once all that's screened out the drug screen and they're acting this way, then you have all these criteria. Then you can say the patient has had a manic episode, and if they've had a manic episode, they're bipolar 1. Okay? Is that making sense? It actually makes pretty good sense. They're interesting people. Okay, let's look at bipolar patient in a manic phase. This will help. Yes, just do it. This is about 6 minutes, 5 or 6 minutes.
Well, Mary, I'm glad you could come back. Can you say how you're feeling this morning?
Oh, on top of the world.
Okay.
On top of the world.
What are your plans for today?
Oh, it's just going to be one great day.
What are you going to do?
Well, whatever my doctor says I can do, I should say that right now.
Tell me a little bit about that. You mean that you may have some restrictions?
Yeah, still.
Uh-huh.
I went off with my husband last night. I beat him up.
What? Now, tell me about that.
Well, I wanted him out of there.
He came to visit?
Yeah, he came to visit me.
Okay.
And he pissed me off, so I wanted him out of there, so I beat him up.
Now, what do you mean you beat him up?
I forcibly beat him up.
You hit him?
Quite a few times. Oh, yeah, slugging it out.
You were saying something earlier about Jesus Christ and the CIA.
Okay, I'm in incognito for the Lord, God Almighty, Jesus Christ.
Mm-hmm.
Okay, I'm working for Him. I have been for years.
Now, what do you mean incognito?
I'm a spy.
And what's your mission?
My mission is to fight for the American way.
Can you say more about it?
The Statue of Liberty.
Okay. But I mean, can you talk more about the kinds of things that you have to do or have been doing as part of that mission?
Oh, I can bring up the wind. I can bring the rain. I can bring the sunshine. I can do lots of things through Christ who strengthens me.
Okay. I mean, you can actually cause the wind to come up?
Oh, yes.
Could you do that today if you wanted
Sure.
to?
Oh, yeah.
And what gives you the power to do that?
God.
On our walk down, you were mentioning about the air and the smells, and we saw some flowers. You like the outdoors?
I love the outdoors. It's my favorite place to be is outdoors.
Yeah.
Well, see, when I first met my husband, can I just talk?
Sure, please.
When I first met my husband, we lived underneath a bridge and down at the boat dock. We weren't married.
Mm-hmm.
But I believe we got married in the eyes of God down at this boat dock
Mm-hmm.
because he popped my cherry, and I had been married before.
When we first sat down, we asked if you could take your gum out, and you had some strong feelings about that.
I've chewed since I was a little bitty kid. Don't hurt my teeth or nothing. I got strong teeth, and I like hard gum.
Mm-hmm.
I like to blow bubbles with it.
Okay. Is that a good piece?
Yeah, it's a real good piece.
Okay.
Want a piece?
No, thanks. Talk a little bit more about the way that sometimes you start crying. I mean, what's the sort of thing that can get you crying?
Missing my mom for one.
Okay.
She died at bridge. My mom died
I think so.
April 5th, 1993.
Uh-huh.
My mother passed away.
What happened?
Well, she hadn't walked for 21 years of my life.
Mm-hmm.
Am I still focused?
You are.
Okay.
That may be a delusional reference.
That's not funny then. Am I still focused? Okay, anyway. Back to seriousness. Okay. She had cancer of the spinal cord when I was 11 years old.
Mm-hmm.
They had to take out her backbone, 8 inches of her backbone out to kill the cancerous tumor.
Mm-hmm.
So that means she was paralyzed from her breast down
Mm-hmm.
for 21 years of her life. She died the age of the year I was born, 61.
Mm-hmm.
I believe everything has a purpose under heaven.
Yeah, what do you make of that?
I believe that's the time that God wrote down she was going to die. Before she hit her 62nd birthday, she was going to die and be my guardian angel at 61 of the year I was born.
You mentioned the other day that drinking coffee, something happens to you.
I get drunk on it.
Say something about that.
I can get drunk on coffee. I can get drunk on water. I can get drunk on Kool-Aid, I can get drunk on lots of things.
Now, can you get drunk on those things at all times or only at certain times?
When I'm high,
When you're having one of these up
Yeah.
periods? Are there times when being up like this is unpleasant?
it always feels good. Never feels unpleasant at all, except for when I can't go to sleep because of it. When I'm too up and I cannot sleep. That's the only bad part about it.
How did you sleep last night?
Worth a damn.
Not good.
No,
How many hours?
I didn't sleep at all, I just rested.
Even though you didn't sleep last night, you still have good energy?
Oh, yeah.
Do you feel as good as if you had gotten a full night's rest?
Oh, yeah. Big time.
Okay. Were you able this morning, feeling this good, were you able to concentrate on things that you wanted to
Yeah.
concentrate on?
Sure was. I helped him put some stuff away. I folded laundry. I
Okay.
stocked socks together.
Okay. Do you think that if you were outside the hospital right now, you'd be able to do all the things that you needed to do?
Oh, yeah.
Sometimes when you're feeling this good, do you go out and do things that get you into some kind of trouble?
Oh, sure.
Like what?
Mess around with my husband.
Okay. And it gets you into trouble?
Big time.
Yeah.
And the voices, my gosh, can I hear the voices?
Talk about the voices.
It's what's around me, like up at the front desk. People outside my window, I can hear them all.
Now, are these voices of people that you can't see?
Right.
Okay. What kinds of things are they saying?
Well, it's none of my business, really.
Is there anything else that you want to mention?
Yes, I'm a morphodite.
Yes, talk about that. You mentioned that to me one time.
Okay. I'm a male and a female mixed.
Okay.
I have both organs. And I believe that that's the way God is up in heaven.
Okay. Mary, I want to thank you for coming back. So we've covered a lot of things.
Yeah.
Okay. Thanks again.
Okay. 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 Well, that a picture's worth 1,000 words. Did you see her? I mean, that's pretty bizarre. I'm not sure that she has sexual parts from both, but that would not be unusual where they would think that was true. So that could be another delusion. She had hallucinations and delusions. She had auditory hallucinations, and she certainly had hypersexualism. She beat the crap out of her husband. I mean, so you see the range of possibilities. But she was kind of fun. I mean, you get that response. And that is a fairly typical response that you will see. Okay, let's take a break. I'm going to give y'all, let's do 5 or 10.